Morning.
Morning, madam. Morning.
Morning, sir.
How are you?
I am good, sir. How are you?
Also well.
What's the problem with the sound?
Full volume.
Am I audible, sir?
Yes, madam.
Okay. Huh? Do I share my slide once?
Yes, ma'am, please share. We can try.
It's fine, right?
Yes, ma'am.
Okay. Mhm.
A very good morning to all of you. Indian Pharmacopoeia Commission National Coordination Center for Pharmacovigilance Program of India is celebrating second National Pharmacovigilance Week commencing from 17 to 23rd September 2022. Today is second day of National Pharmacovigilance Week. I am privileged to inform you that Pharmacovigilance Week is celebrating throughout the nation. I am pleased to welcome all the guest speakers, higher officials, stakeholders, coordinators and deputy coordinators of our AMCs throughout the nation and IPC PvPI team for attending second day program, that is PvPI stakeholder meet. Now for our today's first session, I want to invite Dr. Ananya Chakrabarti for sharing pharmacovigilance experience from an AMC. Dr. Ananya Chakrabarti, Vedi Institute of Medical Sciences and Research Center, Professor and HOD Pharmacology. She has postgraduate and PhD guide, coordinator of Pharmacovigilance Unit, Vedi AMC, NABH Internal Auditor, Chair of Institutional Animal Ethics Committee, WIMS and Research Center. Vice Chair of Ethics Committee, Manipal Hospital, Bengaluru. Core Committee member of South Chapter of Indian Society for Clinical Research. Prior affiliations, research scientist at the University of Washington and medical content manager at INGEN, Bangalore. MBBS and MD in pharmacology from Regional Institute of Medical Sciences, Imphal. She has close to as 50 publications in national and international index journals. She has organized many CMEs and national and international conferences, delivered invited talk for academia and pharmaceutical industry. Welcome you, ma'am. Over to you.
Thank you. Wishes to everyone for a successful Pharmacovigilance Week. I thank PvPI for this opportunity. Let me share my slides. Yep. So it was the year 2005 when I joined Vaidehi Institute of Medical Sciences. We had a symposium sometime in 2006 where we collaborated with clinicians from various departments. My topic was to discuss the mechanism of action and adverse reactions of drugs used in bronchial asthma. And we discussed about drug discovery and safety aspects and post-marketing surveillance. So I would say that was the first meet where I could share my knowledge of pharmacology with a broad clinical specialty and super specialty departments, and I got to know them and what happened after that. Yeah, so let me share with you the story of our first report. And I feel, that symposium, I think that was the starting point for us. So after the symposium, I received a phone call from a clinician, from a dermatologist of our hospital in the year 2006. I think that was within 1 year of me joining this institute. And there was a case of hypersensitivity reaction in his department, and he wanted to know whether there is a process, for reporting it. And then, even to tell you, like, even I had no idea how to report. So I had to inquire, I had to make few calls to my colleagues. I had to look into, some publications. And then what I found out is at that time, there was one peripheral center in Bangalore, and that was at Alamein College of Pharmacy. And even today, I remember, the day I had called Dr. Shobha Rani madam, and, I requested madam, and madam had guided me about how to report a case of ADR. And madam had sent me the form, over email. And then we downloaded the form, we noted down the case, and then we had mailed back to Madam. So I think it was the year 2006, end of 2006, that we had reported our first case of adverse drug reaction to the peripheral center that was available to the coordinator, Dr. Shobha Rani Madam. And if I don't know whether Madam or Madam's colleagues are there in this meet, but I would like to thank Madam and the team of Bangalore Al-Amin College of Pharmacy to guide us through the process of reporting adverse drug reactions. So with this background, the outline of my talk will be to discuss the story of Vaidehi AMC, the establishment of the center, the process flow, the contribution to pharmacovigilance program of India, the positives, that opportunity to advocate for scientific cause of medication safety, then possibility to collaborate with multidisciplinary teams, the chance to bring recognition to the department through publication, through CMEs and other events, and then the challenges that we face, the sustained effort towards reporting culture and data acquisition, and the need for stable support in terms of manpower, requirement of a secretariat, etc. So in our hospital, we had established the ADR center in the year 2010. I still remember, we had a MCI inspection, and then, the inspectors wanted us to show that, we are part of pharmacovigilance team, and then we document adverse drug reaction reports. And luckily, after the incident of 2006, once we reported the case to Madam, and Madam had suggested that in future, if we want ourselves to become a center, we should start filing all the adverse drug reactions that we receive from the hospital. So that was sort of easy for us, because we already had, I should say that over from 2006 to 2010, around 20 reports documented with us. Right. So then, we had a room with the internet and, a phone facility, and we started the center, and then we had placed an intent to the PvPI for recognition of our center. And in the year 2011, I think it was the month of July 2011, when we received the recognition, as a ADR monitoring center. So initially, the center was located in the Department of Pharmacology, but I will tell you in my next slides that we used to face some challenges. So finally, we decided to move to the hospital. So our center is located in the ground floor of our hospital building. We have a Ganesha idol, and right behind that Ganesha, because people usually, patients, doctors, in the morning, they go and pray in front of Ganesha, and as they disperse from there, so ours is the first room in the hospital. So I want to say that we are very much visible in the hospital. So in the initial days, the AMC was located at the Department of Pharmacology, and the team of pharmacovigilance unit was constituted with like-minded colleagues. And we made sure to include our dermatologist colleague, who was the first person who motivated us to report our first case, to include him in the team. And Sir had successfully completed his tenure as the deputy coordinator of the AMC, I think till a couple of years back. Yeah, so we used to have monthly meetings, and most meetings were about strategies on networking with clinicians. And in all meetings, we would talk about meetings over a cup of coffee, because that is the time where we could have some informal meeting, and we could pitch in the topic of reporting adverse drug reactions. We eventually came up with a master PPT for awareness session. So the pharmacovigilance team members were divided into groups. So each person got to network with around 5 clinical departments. And I still remember today I was given the charge of networking with the Department of Psychiatry, the Department of Oncology, and Department of Neurology. So like me, other members also got the charge to, network and to collect report, to increase the reporting from, 3 to 4 departments. And what we used to do is during the department seminars, we would go there and just request 5 minutes time. And we would talk to them about the importance of reporting and how to report. ADR forms were distributed whenever needed, right? Whenever we used to receive a phone call from a colleague that there is an ADR, then we used to send the ADR form. And most of the time, we used to ourselves document the ADR because I think there are many publications which state that clinicians don't have time. So because of the time thing, we used to make sure to go ourselves and collect the report and to fill the report and to upload the case. Members were encouraged to attend events on pharmacovigilance. So by this, I mean to say that, we received very good support from our hospital. The first official event of AMC was a state level workshop, pharmacovigilance in Outlook. Pharmacovigilance and Outlook. So it was attended by more than 100 colleagues from across Karnataka, and we had guest speakers from academia and also pharmaceutical industry. If I remember correctly, there was one of our colleagues who used to work in Biocon, and he was in medication safety, and he had given the session on PSURs and the industry perspective of pharmacovigilance. So our center was recognized in 2011, and the first official event was a state level workshop that was, I think it's mentioned here in the January 2013. The picture is little hazy, but at least we could see the date and the year. We were very privileged to also organize the National Symposium of Pharmacovigilance again in the year 2013 at IMA Hall, and it was attended by more than 300 colleagues from almost all institutes of Karnataka, and we had the presence of Dr. Y.K. Gupta sir. Like we all know that he's a pioneer of pharmacovigilance in India, and then the IPS president Dr. Diwan, and then Dr. Bikash Mehdi sir was there, and Dr. Raju Koneri from Karnataka College of Pharmacy. Yeah. So with this background, again, I want to tell you about the evolution and strategies over the last 10 years. So initially we used to, send the ADR forms to the doctors, and we used to personally go and help them fill the form. But with time, we kept the forms at nursing stations. But here I mentioned that, no Dropbox. I know there are many institutes who came up with this innovative idea of having a Dropbox, but we had decided against the Dropbox. And this was because we wanted to network with the person. We wanted to know, because, in a hospital, in a super specialty hospital where you have so many, more than 500 healthcare workers, and initial days, it was not possible to get to know each and everyone. So we took this as an opportunity to know the people who were motivated to report cases. So we didn't keep the forms at the, we did not install a Dropbox, but we kept the forms at the nursing station, and we would ask the nurse, to inform us, and personally we used to go and talk to the doctor. We also started initiating thank you cards to reporters to keep the motivation, going. And, like usually it happens when a new thing comes up, right? So people who report, they sometimes get bullied by people who don't report, right? So to keep their motivation going, we started giving them thank you cards. We also started acknowledging the best reporting department in my institute. Every month we have HOD's meeting along with the administrators. So in those meetings, we used to mention the best reporting department. And then we eventually we came up with a subcommittee to the PV team, because we wanted one point of contact from each department, so that it's easy to talk to that person from that department, and to send across all the messages, all the flyers, all the newsletter that PvPI sends, so that he can go and forward it to his department team. So because of underreporting, we decided to have ADR stickers on the case file, so that the nurses can identify those files, and then they can inform us. And then we also came up with, after the ADR stickers, we also came up with this, because many a times even the ADRs won't be documented. So we came up with these case files with designated ADR box, where the physicians need to mention in the box whether there is an ADR or not. This is also to reinforce reporting culture. Now, as we move to online medication management system, we made sure to talk to the administrators and the team, and to have a ADR drop-down menu. Right? Even today, we have the ADR drop-down menu, and we do regular audits of our inpatient and outpatient prescriptions and case files. And, we check. And, they cannot keep the box as empty. They have to mention ADR or no ADR, and then they have to put their signature, right? And then, as we started working towards NABH accreditation, I think way back in the year 2016 or so, we started documenting medication reconciliation. And this really helped, because I'll give you example. We got cases where, say, diabetic patients, right, when they walk into the hospital, they are quite serious, right? So the doctor sees the patient, and they eaten the drugs, the nurse goes and gives the medication. But since diabetes is a chronic disease, so what happens? The patients are already of the habit of taking their medications. So they bring their medications, and then even if the nurses administer, they take their own medication. And then we started getting cases of hypoglycemia because of administration of insulin twice. So then this medication reconciliation, so we had to go and, we had to initiate awareness sessions on medication reconciliation. And then again, like, ADR box, now in the case files, in the first page on the right top, we have a box for medication reconciliation. So every month we do 400 audits of inpatient files, right? And again, so the doctors are supposed to write the names of the medication that the patient is on when they get admitted, when they are shifted from ICU to, to the ward, when they're shifted from OT to the ward, likewise, right, in various, from various units of the hospital. So we also started orienting nurses towards a double check for LASA and high risk drugs. We know that, insulin is a high risk medication. So double check means, they have to check the files, and they have to again talk to another colleague. And while administering the drug, they need to make sure that they double check and administer the LASA drugs. We have made a list of, LASA drugs of the hospital based on our formulary, and right from pharmacy at all stations of the hospital, we have those lists, and we aware the nurses every month on the use of LASA and high risk medications. Sometimes to our surprise, they sometimes don't know that, noradrenaline, adrenaline, and epinephrine, that they are the same drugs. So we have to go down to that level of awareness. So as I mentioned, with NABH accreditation, we have to send the quality indicators for NABH, and pharmacovigilance is a component of NABH management of medication. So number of adverse reactions that happen due to high risk medication, again, we started documenting. So this is how we evolved over the last, last 10 to 12 years. So just, reporting the center from being there in the department, we shifted to the hospital. And then, now I think the process is quite set. And we keep doing awareness sessions. Without that, even, the reporting goes down. But we are happy that we get many cases from the clinicians themselves, at least 20 cases. They themselves come and report to us. So bringing a reporting culture, I think it was possible because of the awareness sessions, during department academic seminars, during new staff orientation, during internship and postgraduate orientation. We make sure that there is a session on pharmacovigilance, and then we mention about the unit, and then we give them the numbers. And then through CMEs, workshops, and conferences, we do at least one event every year on behalf of our Vaidehi AMC. And we are very thankful to the Pharmacovigilance Program of India for supporting us through these initiatives. Now, again, reporting culture, I think it is good because of involvement of stakeholders. Like we have monthly quality indicators for NABH, then monthly feedback sessions during medical executive committee. We have another committee in the hospital to whom the PNT and other committees report, and they take a stock of, the situation in the hospital. And, we have to discuss the adverse drug reactions that happen in the hospital, along with the batch name, along with the, the company details, the patient details. Like we have to present the narrative to them every month, and then update on status during monthly HOD meeting. So bringing the reporting culture, again, as I mentioned, it's possible because of PvPI initiatives, because they mandated now that we take up monthly awareness for healthcare professionals and consumers. So we talk about pharmacovigilance. Because of these directives, actually, it becomes easy to, easy to convince our administrators and our colleagues that, we need to do such programs. We need to make the consumers aware of the medications they take. And then also community outreach. So what we do is every month we go to the field along with our community medicine department, and then we visit the houses of patients. And like what we tell, that even when you eat brinjal, it can cause itching and rashes. When you take prawns, some people may be allergic to food, to peanuts and others. So like that, you can consider drug also as food. So if you face anything when you take a drug, so you can just inform us. You can talk to your healthcare provider, or you can make a phone call. So, I think we are doing this over the last 6 months or so. And over the last 6 months, we did receive, one call from a patient. So we are happy with that, right? We started, and, it's taking the shape. The newsletter that is forwarded by PvPI, we make sure to send one copy to the central library, one copy goes to our department library, and the remaining copies, we forward to the under-reporting departments. Now you can ask me why to under-reporting departments. So this is only to make them understand that, so much is going on in this area, so that, at least they get some motivation. The alerts that PvPI forwards, we make sure to forward them to the all staff mails, and the reporting status also we forward to all heads of the departments. I think Pharmacovigilance Week is a very, very good initiative. We are thoroughly enjoying that from the last year. So last year and even this year, so we distributed alert cards to patients. So we displayed the posters, and as per the PvPI theme, we have undertaken various competitions on the theme of medication safety. So let me tell you the story of amlodipine at our hospital. So between 2010 to 15, we had received 2 reports. Like there are so many, almost like 25 to 30 reports. I think we report every month. Sometimes it goes up to 40 to 50 also, but I am saying on an average right from the beginning. So there's so much data, so I didn't compile everything, but I thought I will tell about amlodipine. So between 2010 to 15, there were 2 reports of ADR on amlodipine, pedal edema, and 1 report was on headache. And we all know that pedal edema is a very common, more than 50% maybe. Like it's a very common ADR, and amlodipine is the most commonly prescribed antihypertensive from our hospital. So 2 ADRs between 10 to 15, that is over 5 years. 17, we received 3 ADRs, and 2018, we received 9 ADRs on amlodipine, 8 pedal edema, and 1 case on gum hypertrophy. So please note this point, 1 case of gum hypertrophy. 2019, again, we received 1 case of gum hypertrophy, and likewise, and we reported, and we are very happy to have contributed to this because PvPI has, I think 2019, they have sent this, update. So in the meeting, PvPI evaluated the drug amlodipine ADR on the basis of ICSRs and recommended CDSCO to take necessary steps to incorporate gingival hypertrophy as an adverse drug reaction into the prescribing information leaflet of the drug amlodipine marketed in the country. So, when we received this, we felt very proud to have contributed to, at least to very little extent towards this, addition to the package insert of amlodipine that, the drug can cause pedal edema. And, we highlighted this during the HOD meeting, and, we took out our files and we encouraged these 3 clinicians, 2 were from Vaidehi Hospital and 1 doctor was from Vaidehi Institute of Dental Sciences. So we did make a mention of these doctors, and we encouraged others also to do such reporting. So towards safe medication practices, we distributed a wallet card for patients. So here is a photo of last year PV week. So, I am sharing the photo of the patient because we have taken his consent, and he was very happy. So this is a alert card. The patient is on chronic hypertensive drug, and the treating doctor, she handed over the alert card, and we told him to carry it in the wallet so that, every time he goes to his doctor, he can carry it, and he also can remember what drug he is on. And this year also we have printed medication wallet card. We'll start distribution, today after the meeting. We also came up with a manual for healthcare workers because, every time we go for the orientation, they ask us like, what is a side effect and what is adverse effect? Like after 10 years of orientation also, this is the question that clinicians ask. They ask why to report. They ask like, how do you grade ADR? What is mild? What is moderate? And why should we report mild ADR? So we thought like, let us compile everything in one document, and so that the document also will have the phone number details and the constitution of the Pharmacovigilance Committee. We also have conducted awareness session outside the institution. So this is me, talking about COVID vaccine, right? The why people should take the vaccine and what effects they can have. So this was a program on Doordarshan. Okay, so this is again, as I have been asked to share my experiences. So I think, I feel very proud to share this. So what happened is, like, as I told you, right, because of our symposium, CMEs, and various events, we got connected to the clinicians. They started asking for drug information. We at least, every month, at least 2 to 3 drug information we provide to the clinicians. So what happened is levetiracetam was just marketed and it was new in India. So this neurologist, he wanted to give this drug to a patient, epilepsy patient, and this patient was nursing her, I think 6-month-old baby. So the patient used to speak my language, and it was very difficult to convince the patient that she needs to take anticonvulsant. She was very worried. So I get a call. So I go to the neurology department and I talk to the patient. And also, as we are aware about the various effects of the drug levetiracetam, I made sure to talk to her, to take her into my confidence, and to find out about the family history, whether there is any history of depression, psychosis in the family, or whether she suffered from any such episode in the past. So after successful evaluation, as there was no such history, so we started the patient on levetiracetam. Now, after the patient went back home also, I remember 2-3 times I received call from the patient whether the drug is safe, whether the drug will be secreted in breast milk. And then, she used to keep calling me whenever she got, breakthrough seizures. And then I would connect to her neurologist and send the prescription. So, we somehow developed a communication channel, and she was quite comfortable to talk to me. I think almost after 6 to 8 months, one day I had just come to the department. It was around 9:30 a.m. I got a call from her, and she told she feels like committing suicide. Immediately, I told her, you keep talking to me. And then, with the phone, I ran to the PG room and I sent one of my postgraduates to her house. Apparently, her husband was out of town and she was at home with her, infant. So my student rushed to her house. Basically, her house was, I think, around 5 kilometers from our hospital. So he went and brought the mother along with the kid. And then we immediately, took her to the neuro, then psychiatry. And then, we finally referred her to Nimhans for counseling. So then, I was talking to her, like, what makes you sad? Why do you feel like committing suicide? Then she's like, she has a son from her first marriage. She has left her son with her parents. And whenever she nurses her second son, that is from the second marriage, she keeps remembering her first son, and that gives her negativity. So then I asked her, right, why didn't you talk about this? Why didn't you tell me that, you have another son? Like, when I talk to you about, anything, any significant thing in your history, then, she was like, it's because of the stigma. If I had told you that time, you would feel, I think because of the culture, right? We don't feel like sharing such critical information, right? So today, like, I think so that incident happened, I think, in the year 2014. And after so many years also, whenever I remember that incident, it gives me goosebumps. And I feel, on the other hand, I feel very proud and happy that, we could save her. So I think this is the main reward of being, being an advocate of medication safety. So recognition of the department, that is another positive, right? So what type of recognition? Yeah, so our students, they come to the department, they want to take up projects in pharmacovigilance. So we also received ICMR and RGUHS grants for student projects. Then faculties also do take up projects, and our students, they have presented, right from, I think, 2012 onwards, they have presented posters. And then we have publications, at least 2 publications on pharmacovigilance from the unit. And then we received increased visibility in the hospital. Then industry academia collaboration, I will come up to that in my next slide. And then, we are sort of stakeholders of overall management of medication of Vaidehi Hospital. So recognition, like last year, right, I received this from PvPI. So it was an impromptu decision, just I was playing with Canva and I loved playing with the colors, and I just submitted the poster and we received the 3rd position. Very recently, MNC Novo Nordics reached out to us because they wanted to have their new joinees come and see the hospital functioning of pharmacovigilance. So we had around 25 employees of Novo Nordics. It was conducted on 30th June 2022. So around 25 employees, walked into the hospital. So where in the lobby, first we had a skit that was coordinated by our pharmacy college students. So the skit was to show them about orientation of patients, right? How we orient our patients to the concept of pharmacovigilance. Followed by, we had a case simulation in the Department of General Medicine where my colleague, who is also part of the pharmacovigilance team, so she simulated a case of pharmacovigilance. And the same case, then they came to the department, and this is our simulation lab, the CAL lab. And, we gave system to each participant, and, we asked them to try uploading the same case through VGFlow. So, of course, they did not submit it. It was a hands-on, experience for them, like to get to know of, the software that we use. And we again thank PvPI for, giving us the permission to conduct this event. Recognition again, like we started receiving reports from nearby healthcare centers like Manipal Hospital, Whitefield, Chakra Hospital, and other medical centers. And then we do verify the consumer-based reporting as and when PvPI forwards to us. And then, we were part of the pandemic vaccine vigilance. We collaborated with the community medicine department. So till date, as I mentioned, we have had at least 2 publications on pharmacovigilance, and I am showing some of my publications. So this is a publication where, we coordinated with neurology and general medicine department. As I told you, in the year 2011, I was given the task of, creating awareness in oncology, neurology, psychiatry departments. So here you can see, like, my paper is on neuro. And then, yeah, this is again another case of psychosis, very beautiful case that we published in IJP. Then pelonosetron-induced ventricular tachycardia in patient receiving cancer chemotherapy. So all these are published in PubMed Index journals. So this was with Dr. Shashidhar. He is the HOD of oncology. And then very recently, we tried to, go to the community level and collected the adverse events in selected apartment complexes around Bangalore. So this is also published in the PubMed indexed journal. So I really thank that, that we are part of the pharmacovigilance team, and because of which we are able to take up these projects and see through the successful completion. So let me talk about the challenges now. So the challenge, I think we all agree, it's the sustained effort towards awareness and networking. So they say human behavior, that is knowledge, beliefs, and motivation, plays an important role in ADR reporting. And these can be challenged only through educational interventions and relation building. Even today, yeah, we discuss pharmacovigilance over a cup of coffee. So the common questions even today that they ask is, what's the distinction between side effect and adverse drug reaction? Why should I report the reaction that I know, that is documented in textbooks? Why should I report that reaction? Why to report mild reactions, right? And the other, so towards this, I think the positive goal is, if we read articles from, I think SAD had a publication, so that mentions that, from various developed countries, the consumer-based reporting, has played an important role in pharmacovigilance, and they have found out that the percentage of consumers reporting cases and doctors reporting cases is almost 50-50. So in this perspective, we are very happy that PvPI has come up with the app, and nowadays we are focusing more on, creating awareness in the consumers, and we are going down to the community level to talk about adverse drug reactions. And we also have a toll-free number to report adverse drug reactions. So with all this, I still feel the need for stable support in terms of manpower and time management, that we really find it difficult. So we do have associates, but like sometimes we have to train them, and once they are ready to deliver more, it's the time for them to leave. So I would request, the team, if we can have some way of having, associates, stay with us for longer time. So then it helps, because once we set up the SOPs and everything, we start working nicely. But then, then suddenly they come and say that, I need to leave. So I don't know. I think maybe we can find out the reasons. And time management, one thing is, like, now we all are handling the CBME batch medical students, but we need to spend more time for that. But on the other hand, in the CBME curriculum, so Government of India has focused more on these topics like medication safety. So we are required to take even students to the ADR monitoring center. We need to give them cases, and we need to, we need to score. That is a competency, right? So we need to score how they report. So all these things are positives. And at our institute, so we also include the other paramedical, dental, students. And then we work very actively along with our pharmacy institute, right? And like pharmacy students also come to our department, and every day for 1 hour we take them for rounds to the various departments of the hospital. So with all this, I would summarize saying that human behavior, knowledge, beliefs, and motivation plays an important role in character building as medication safety advocate as well. It's not only for reporting, but also as a medication safety advocate. There are challenges, but together we can achieve the Herculean task of reducing the preventable errors and thereby reduce patient harm. Thank you. Any questions? I think I still have 3 minutes left, so I thought I will finish and take up some questions.
Thank you, ma'am. Thank you for a wonderful presentation. Ma'am, I would like to know, how do you connect to the consumers? Like, are you receiving any reports from the consumer background?
Yes, as I mentioned, like we collaborate with the community medicine department of our institute, and along with them, we visit the field, the PHC. Okay, and then along with them, they go door to door and for awareness on vaccines and all, right? So along with them, we go, one member goes to the team every month, right, to the field, and we talk about reporting adverse drug reactions. So after doing that, as I mentioned, over last 6 months ourselves, we did receive one call from a patient. Other than that, every month we orient patients and their relatives. Actually, we visit the hospital lobby and we talk to them about adverse drug reactions, as required by PvPI. Also, now the associates are supposed to do orientation. So at least 15 to 20 patients or caregivers we try to talk to. Okay, so this is a program in-house, and also we do programs in the community level. So these are the two things. And the third aspect is, nowadays we often receive mails from PvPI. Whenever a patient reports, we do verify the claims, right? We talk to the patient and we see if this is a genuine case. I think over the last 6 months, at least 4 to 5 such cases we have verified.
Any more question from anyone? Madam, it was an interesting presentation, and you have shared your knowledge and your experience, and how you are reaching to the community level and to the consumers at the individual patient's level. Madam, I would like to have one comment.
Yes, sir.
Are you getting the feedback from the patients also, madam?
Sir, feedback like in terms of adverse drug reactions, sir?
In terms of the improvement in the adverse drug reactions, if they suffer the adverse reaction.
Sir, I think we will take it up as a study if you permit us. Because
think-
that's what even yesterday itself, we had a discussion in the department, and what we thought is, till date, there are many published articles on knowledge, attitude, and practice of ADR on, healthcare professionals. But I don't think we have done this type of studies in the patient population. So I think it is the time we will take up such a study, and also we'll start, taking feedback. We have not done that, sir. Thank you so much for the input.
Okay, thank you so much for encouraging each of the audience and for your nice presentation and how you have handled all the ADR issues in the past and kept your team self-motivated and motivated by yourself. So thank you so much, madam.
Thank you, sir.
Thank you so much, ma'am, for sharing your wonderful experience. Thank you so much. So now we are moving to next our session. That is, I would like to invite Ms. Arshia Bhandari to deliver a session on reporting of adverse events, consumer perspective and NGO perspective. Ms. Arshia Bhandari is a professional pharmacovigilance. She has 16 plus years of experience in end-to-end pharmacovigilance process with blue chip pharma companies across the world. She has previously worked with Quantum Solutions India and Parexel Internationals and currently works with IQVIA. She has written several articles on PV and patient safety initiative in India that have been published in WHO publication, Uppsala Reports and DIA Global Forum. She has a member of International Society for Quality in Healthcare, Global Pharmacovigilance Society, and an advisory board member for Patient Academy for Innovation and Research. She is also the founder of PhVFit, a thought leadership forum that works towards bringing holistic awareness regarding patient safety principles and pharmacovigilance through open dialogues in different forums. She has delivered several talks on different platforms like AIMS, New Delhi, Chitkara University, Chandigarh, Swasth Wellbeing, Delhi Society for Promotion of Rational Use of Drugs, Integrated Health and Well-being Council on Pharmacovigilance and Patient Safety, and has been raising awareness about the cause through various campaigns by PHV Fit with support from leaders across the industry. She is also a certified business storyteller and has trained around 300 NGOs on storytelling for impact. Welcome you, ma'am. Over to you.
Thank you very much for the warm introduction. I hope I'm audible.
Yes, ma'am.
Okay, great. Thank you very much. So at the outset, I would like to thank Indian Pharmacopoeia Commission and PvPI for inviting me for this event, for the stakeholders meet. It is really an honor to be here. And I'm very happy to contribute and share my insights on consumer reporting. Thank you so much. Let me share my presentation first. Just give me a moment. Are you able to see my screen?
Yes, ma'am.
Okay, great.
Kindly put it in the full screen mode, ma'am, please.
Yeah, I'll do that. Thank you so much. Yeah, so thank you very much again. And before I start my presentation, I would like to thank Dr. Ananya Chakrabarti for such a insightful and informative presentation that she gave and the experiences that she shared. And it's really, it's the kind of dedication they have at the Area Monitoring Center. I think it's in really good hands. And if this is something that is followed in each and every AMC in India, we would really be, at the center stage of pharmacovigilance in our country and across the world. Thank you so much. All right, so what I will be taking is adverse event reporting from the consumer's perspective, and I will also be covering the NGO perspective or the patient organization's perspective to an extent. So to start with, a little disclaimer: the views in this presentation reflect my personal views and do not necessarily reflect the views of the author's employer or any other organization the author may otherwise be collaborating with. So, okay. So just to give you, a brief about what we will be covering in this presentation. First of all, we'll cover why consumer reporting. Why do we really need it? Then, what are the observations and experiences from across the world? What are global best practices? I'll take one case study from EMA. Then who are the stakeholders who are important for implementing and facilitating consumer reporting? How patient organizations or NGOs can help? And finally, what is the way forward in conclusion? All right. So to start with, why consumer reporting? That's the, one of the major questions that we have. And from a healthcare professional or even a layperson's perspective, I would see the first thought that comes to us is if patients would really be able to report effectively. Since they're not medically trained, a lot of patients or consumers or caregivers do not have medical literacy. Would they really be able to decipher adverse events, identify them, and then, will that information really be important enough or effective enough to be included as signals? Or would it be noise? So, is the events that patient report, are they signal or noise? So let us see what the observations from across the world have been. And, first of all, I would like to, I've given a reference here from one of the studies that was conducted in 2018 by Uppsala Monitoring Center and Netherlands Pharmacovigilance Center, LEREB. And it was to explore the nature of safety signaling reports in an international setting. So what they did, they collaborated in a signal detection workshop focused on patient reports in VIGI-base, and that is the WHO global database of ICSRs. And the objective of this paper was to describe the results and reflections from this exploration. So I'll just briefly share what were the major findings in this study that they had done. So of the 212 combinations that were assessed, 20, that is 90%, resulted in 8 signals. And these ICSRs or the reporters from these ICSRs were completely, only the consumers or the patients were chosen. So it resulted in 8 signals communicated within WHO. They realized that patient reports typically contain more detailed information on quality of life, severity of the adverse drug reactions, and circumstances of use. Then they also reviewed the PILs, that is patient information leaflets, that reveal that insufficient area descriptions for patients and examples of, and there was poor consistency with product information for healthcare professionals. So there was a gap on how the patient or the healthcare professional is understanding the kind of adverse events that would occur. And this was studied, and then the risk minimization measures were taken then. Then patient narratives provided a lot of details regarding the experience and impact of areas and evidence that patients make causality assessment and causality and personal risk assessments. Then safety concerns described in patient reports were identified in this global database and provided information regarding previously unknown areas as well as new aspects of known areas. So, from these examples, I would say that it was realized by the Uppsala Monitoring Center in Lereb that the information that is coming from patients is not noise. There are a lot of signals that can be identified from patient reporting. And in my further slides, I will talk about other observations from across the world, from EU and US, from the other studies that have been conducted in this regard. So in the conclusion of this study, the recommendation that Uppsala Monitoring Center made was that to benefit from the unique information available in patient reports, signal detection practice that focuses on review of case narratives, such as case-by-case assessments, is preferable. Because patients provide detailed information, there can be certain information that has not been reported as an event per se, but that information is provided by the patients in the case narrative, and it is very relevant information that could get missed if we do not consider that. But since the reporting or the number of reports coming could be very, very large, it is also recommended that we need to tailor the statistical signal detection to capture patient concerns. So the data mining that is done through signal assessment softwares. Then so let me share you further observations from across the world. To give you a little history about how the consumer reporting in our world has progressed. So if you see this map, we have you'll know that the consumer reporting has started at different times in different continents and countries. If you see, there's in USA, Americas, it was started very early in 1964 and 69. Then here in South America, Brazil, it started around 1990, and it progressed. The reports increased towards 2005. It has started in India. If we see, we actually started in 2012 the consumer reporting, but there have been a lot of considerations why the consumer reporting has been at a low scale in majority of the countries. There's still a lot of countries where there is no patient reporting system at all, or even the patients are not surveyed for any of the evidences or adverse events. So if we look at why there are differences there, so I would say there have been political and strategic considerations. Then secondly, there have been this confusion whether what patient reports is really a signal or noise. Then what are the qualitative and quantitative aspects of patient reporting? And another very important point is that historically, in early 2000s, there was no evidence, or I would say any studies that were conducted to assess the benefits that patient reporting could have. And in following years, this has been done. And now, as you see, WHO is really focusing on patient and family engagement for healthcare, whether it is towards drug development or consumer reporting. So let me come to some of the observations that have been there. So this is from the Yellow Card scheme in UK, and this was a study that was conducted to assess the qualitative. It was a qualitative analysis on how the reports were that were received from patients. So these are some of the observations. Among members of the public, 8.5% were aware of the Yellow Card scheme in 2009. Patient reports generally contain higher median number of suspected adverse drug reaction per report. The proportions of reports categorized as serious were similar between between the healthcare professionals, the reports that healthcare professionals reported, or sorry, adverse events that healthcare professionals reported, or what the consumers reported. And then there was this observation that has been very, very, I would say, consistent across the world. And this is that patient reports are normally richer in their descriptions of reactions than those given by the HCPs. And they more often noted the effects of ADR on patients' lives, as in how it actually affected the quality of life. And I think this information is very, very important, because then we understand what exactly is the severity of that adverse event that is happening, and that really gives us great information on the risk-benefit analysis of a drug. Then combining patient and HCP reports generated more potential signals than HCP reports alone. The addition of patient reports to HCP reports identified 47 new serious reactions that was not previously included in the SPCs of those UK at that time. Most patient reporters found it fairly easy to make reports, and I will come to the reasons that are there why in UK and EU and US the reporting is fairly easier than other countries. That there were in this study improvements to the schemes that were already there were suggested, and it was said that greater publicity and redesign of the web and paper-based reporting systems needs to be done. And this was done because this study was done in 2011, and we've come a long way from there, and there is a lot of developments after that. Here is another analysis that is from 2018, and it was done in the FAIRS database, that is Food and Drug Administration Adverse Reporting System in US. And here also, it was realized that the number of voluntary reports by consumers increased since 2013 in the US. And one of the reasons that was recognized was that was the introduction of consumer-friendly reporting form, that is FDA 3500B, that was introduced in 2013. Earlier, it was only FDA 3500 that was that was specifically for the healthcare professionals, and the wording in the terminology in the reporting form was more relevant for HCPs, as it was medical terminology. But now in this form, specifically for consumers, it was quite simplified so that consumers can understand what they need to report. Then there was a gradation in numbers, as I said. So from 2,251 in Q4 1997, the reports increased to 13,866 in the FAIRS database in Q2 2016. Then other observations were consumers can add information about AEs that may not be emphasized by healthcare professionals. Again, as we saw earlier, there were signals that were identified through patient reports. The proportion of reports on female patients, and this is one observation that they had in this study, the proportion of reports on female patients and on disability as patient outcome was higher in patient reports than the HCP reports. So it was seen that HCPs usually reported more AEs for males, and they would not report disability usually, or disability events usually, but these were seen more in the patient reports. Then consumers reported more concomitant drugs, and this is probably because the consumers have complete information about their concomitant drugs that they're taking. And if we really look at it, if we have the concomitant drugs, then we also get an idea about the comorbidities that the patients might have, and it could help in the complete assessment of the case from that perspective. Then time to report varied among the occupations depending on the seriousness of the outcomes. And again, as I said earlier, the voluntary reports tended to include AEs related to subjective symptoms. So these were a few of the observations from FAIRS analysis. Then let me come to the next slide. Okay, This is one of the studies from EU, and this was done in 2021, and it assessed the importance of direct patient reporting of adverse drug reaction in the safety monitoring process. There were similar observations in this as well, and it was seen that after 2012, after the implementation of EU pharmacovigilance legislation, where they excuse me, where they defined an obligation to report ADRs received also from the non-healthcare professionals or consumers. The number of reports categorically increased. So from 2011 to 2013, the participation of patients and their caregivers reports increased by approximately 24%. And from 2014 onwards, it reached around 30% of overall reported reactions every year. So we can see from this the study from EU that when the regulatory implements or obligates the reporting from consumers and acceptance of reports from consumers, it creates trust in the patients, and they're able to they decide to report more, and it helps with consumer reporting. Then most reports were from UK, Germany, France, and Italy, and 13 out of 20 frequently reported reactions by patients were also among 20 top reactions reported by HCP. So what I mean is that it was seen in this study that it's not that the reactions that patients are reporting are very different from what HCPs are reporting. It was a very similar, and you can see from this, and it has been studied in other journal and reported in other journal articles also. So it was understood that the patient reporting really complements the reporting by HCPs. Then, so just to summarize, what really determines the higher reporting rate, and I've taken this from a lot of other articles that I read, and it was recognized that countries with higher patient reporting rates seem to share the following characteristics. So one is, the older the reporting system, higher the reporting rate, and that is self-explanatory, that there is more awareness with consumers because the reporting system has been there for a very long time. Then use of patient-friendly terms listed in the ADR reporting forms. So simplified reporting forms so that patients can understand what they're required to report. Then different reporting options, and this is something that we fortunately have in India also, and thanks to PvPI and CDSCO for that. We have the toll-free numbers and reporting forms, or we can report in the area monitoring centers. Then another observation was that when there is patient assistance through chatbots or information or manuals, that how to report or write the adverse event in the online form, it really helped or increased the reporting rates. Then if there is a provision of feedback where patients can give feedback on how it can be improved, the reporting system can be improved. Then engagement with patient organization, and this is a very important point. I'll be coming on it in my further slides. Then implementation of several activities to raise awareness of the general public on the importance of pharmacovigilance. It was seen that different countries promote the reporting system through different media, and it could be television, radio, social media, through Facebook, Twitter, or YouTube. And if I can share an example, in UK and also in US, when the vaccines were being administered, there was a patient leaflet that was given to patients along after they had taken the vaccine, that talked about what they can expect after the vaccination, and if they have a problem, where they can report, and what they can do about it. And I think that really helped, and that would be really helpful, because there was handy information for the patients. They did not need to look outside or on internet or any other places to get that information, that where they need to report if they have a problem. Then in some countries, patient reporting systems are also promoted through HCPs, and this is something I think we are also following in India, the area monitoring centers. And what we heard from Dr. Ananya, the way they are doing the community outreach and reaching patients to support them on patient reporting. Then some countries also created activities to educate the general public on the importance of reporting. And this is something that improved the reporting rates in these nations. And okay, so let me come to this now, that what are the impediments to consumer reporting? If we come specifically, of course, across the world, these are similar, these are common points. But in India also, if we can take why the consumers won't report. So first and foremost, I would say, is medical illiteracy. There are very less people who understand the medical terminology or have the medical understanding. And one reason for this, I would say, is lack of authentic sources of information that we have on disease areas and the drugs that are authorized in our country. And then the lack of awareness, where to report, why to report, and who to report. And if I can share example of with my interactions with patients and organizations that are working on patient safety, unfortunately, the patients do not know where they can report this. Why to report? Why is it important to report? Even if it is a mild reaction or a serious reaction, what will happen when they will report? How is it going to help the healthcare system or the regulatory authority? What changes it would bring? And then, of course, who to report? Though we have, of course, PvPI is there are pamphlets, there is information on the websites, but until that information reaches the patients, it is very difficult for patients to understand where and who to report. Then again, and this is one of the very common reasons why that patients do not report, and that is fear of reporting. That what will happen if I report? Will I be contacted again and again? Will it create a problem for me? Will it have legal complications? And I think this fear is not just with the consumers; it is also with the healthcare professionals, and which is why I think underreporting is one of is there, and I would say, and I will come in my next slides on that it is important that we normalize AE reporting in India. And there is a stop or discouragement to the blame and shame culture, so that this can be changed. Then no understanding on how to identify an adverse drug reaction. Again, this is one problem that is there with the consumers, that what is an adverse drug reaction? Why? How do I know if it is really an adverse drug reaction or it is a new ailment that is there? Then a lot of consumers, a lot of patients do self-management and medication. And once you do self-management medication, I mean, I would say that it becomes your own responsibility. That also will discourages reporting. And this is something that we need to put a stop on. Then lack of support from healthcare professionals. And there is, unfortunately, I mean, through my all interactions, there is still we have a paternalistic approach towards patients questioning their healthcare decisions, or patients wanting to understand the diagnosis. There are when you go to a physician and you ask, and I would not generalize it, but there are a lot of cases where the physicians do not consider it important to discuss elaborately with the patient the treatment care options, or explain to them what the disease is about, because this is something that we need to change. Otherwise, how much ever we say that patients can report, we need to engage patients, we will not be able to make it a reality, because the patients, if they do not have that support system from the healthcare professionals, they will not be able to trust the system as well. Then, of course, the complexity of healthcare system that we have in India. Then, so I will come to the best practices from throughout the world. So first of all, as I said, one of the impediments is the lack of authentic information on disease areas. And if we take examples from US and EU, I've included screenshots here from the various sites, websites, international websites on for A, reporting, and for information on disease areas. So this is from the CDC. There's a complete list of disease areas which patients can refer to if they want to get some authentic information. So one of the major problems, I would say, is the misinformation that is prevalent. And it is often said that patients go to Google and get information from there, and do not have, the term Google doctor is very used very frequently. But I think that since we want to engage patients in their healthcare decisions, it is very, very important that we create authentic sources of information where patients can go and refer to, and then they can take that information to their healthcare professional and discuss with them, so that they can become medically literate and participate in their healthcare decisions or treatment options. This is an example from EMA. So here also, as you see, there's a lot of information and a complete list of disease areas that are there for therapeutic areas where patients can go and see that information. Then that's about the disease areas. Now, they're also from the regulatory authority, from NCAs in EU and US, there are patient information leaflet platforms where they give very detailed information on which medicines have been authorized in the country, and not just that, like if you see here, what are the new medicines that are being that have been authorized, and what is the update about the previous medicines that are there, if there have been any updates on their SPCs or the patient information leaflets, and also the retired medicines or the withdrawn medicines that are not there anymore, authorized in those countries. And this information, I would say, is very, very helpful for the patients, because and it really helps in discouraging the counterfeit products, because the patient can go to the authentic website and see which particular drug they are taking and which company is it authorized for, and it really discourages the practice of counterfeit medicines. Then so first, this one was from EU. Now here I have an example from EMA, that is European Medicines Agency, and here also, as you see, there's a lot of information on what has been updated in the PILs and the SMPCs. If patients need any information on the adverse effects, if I say in India, we do not have patient leaflets or patient information leaflets for all the medicines that we have. I would say for antibiotics we do have. For example, if I buy a Augmentin, there is a patient leaflet and there is all information on the adverse effects. But if I'm going to buy paracetamol or any other over-the-counter drugs, the patients do not have authentic sources of information on how they can see the adverse effects. And I understand, they are being, we are developing ways to do that, the barcoding and everything, but that information needs to reach patients so that they are able to access that information. Then again, this is one example from US FDA on what drug approvals have been done and what updates are there. So in EU, there is detailed, I mean, for every country in EU, there are these registers or lists on which medicines have been authorized, and the SMPCs for that. The national registers for authorized, yeah, so this is the same from there. Then again, one of the very important observation that has been there from studies across the world is that the web reporting really helps in increasing the consumer reporting. So there are web report forms, for FDA, for EU. There are web report forms where patients can just go and at the click of a button, they can report what adverse event they are experiencing. They can add, there are a lot of fields there where they can add history, they can add lab tests, or there is a free text in these forms so that they can add any kind of information, additional information that they want to report. And as I said earlier, after 3500B form was introduced in US FDA, from US FDA, the number of reports increased exponentially. Also, from in EU and in FDA, I would say there's an adverse event reporting system, public dashboard, where patients can go and access or see how many reports have come for a particular drug. In UNC WHO Uppsala Monitoring Center database, VigiBase, one can go and access those reports and see that for which drug, what adverse events have been. And this is something that is not only helpful for patients, it is very, very helpful for healthcare professionals, that because they can, if they come to hear of any such adverse drug reactions from their patients, they can go and have at least a first understanding if there are similar signals that are being reported from other countries on this. Then I would say it's what we've talked about majorly is adverse event reporting in other countries in EU and in US. There are also separate reporting areas, which are also web portals for medication errors, and it is something that is very, very important. And as you see this from National Coordinating Council for Medication Reporting and Prevention, there is a separate reporting form for healthcare practitioners and also from consumers, so that this information, the consumer reporting, can easily happen. Again, this is from the National Patient Safety Agency, and there is separate systems for incident and medication error reporting, which is very, very important, because if we talk about adverse events, it is not just about adverse drug reactions, it is also about the adverse events that happen due to incorrect dosages or overdose or medication errors or surgical errors that happen during. And if these incidents are reported regularly, and there is an established incident reporting and learning system, which is something that we are also trying to establish through NABH and through government initiatives. This could really go a long way in reducing the number of errors. And I would say it's not just the errors that cause adverse events that are reported, or the sentinel events. From the experience in other countries, even the near misses are reported, so that there is a lot of learning from this, and these issues can be mitigated in the long run. Then so again, this is from the National Reporting and Learning System. They have a separate system where the organizations, even patient safety organizations or patient organizations and healthcare organizations can publish their incident reports, so that this learning system or learning can happen. All right. Then again, I would say that there are another reason or another thing that really helps in reporting is our open communication channels. And I've shared this example from FDA and European Medicines Agency patient engagement cluster that has been started. And if you see here, there are several programs that have been started. I'm sorry, the font is a little it's very small, but I'll read it for you. For example, there are the testimonials from patients who have been designated as FDA patient representatives, then how to apply as a FDA patient representative. Then there are FDA patient listening sessions that are there, so that these learning and patient stories can really help. This is one of the screenshots on the testimonials site, where there are YouTube testimonials from patients on the real world experience that they have. Then also I would say I've shared this example from Pharmacovigilance Risk Assessment Committee that is operational in EU. And there are different patient engagement mechanisms. They have to support their assessments, and there could be written consultations, dedicated meetings, then patient representatives at scientific advisory group meetings, public hearings, or surveys. Then it really goes a long way when we have active awareness campaigns where we can engage patients and inform patients about the possibilities of adverse event, the risk minimization measures, and also the possible signals that are being recognized. So this example is from UMC. So this is a UMC YouTube channel where they have different videos on why a patient should report and what they should do, how they should report. Then UMC also has these comic strips for children, where these can be shared with students, and this is something that I and with collaboration with organizations, other organizations like DSP RUD are trying to do with schools, so that this information so these books, these comic strips are mainly about counterfeit medications and antibiotic resistance. And this has been observed from across the world that when that education is being given at an early age, it really gets absorbed and better disseminated. And there is a lot of awareness that gets generated through that. So I'll take one case study after that, and that is from EU on how the risk minimization measures are being taken for this particular drug. And this example is for valproate. So valproate is a drug that is taken for epilepsy and bipolar disorder, but this is completely contraindicated in patients who are pregnant or with patients who have childbearing potential. So as per an EU review in 2014, 2 in 5 babies exposed to valproate in the womb develop cognitive problems and congenital abnormalities. And you would be surprised to know that the scale of this issue and harm caused is bigger than thalidomide. I hope everybody, and I'm sure everybody knows the story of thalidomide. It was 10,000 babies who had congenital issues after their mothers had taken thalidomide during pregnancy. But this issue of valproate, at this present moment, when we have an established pharmacovigilance system for so many years, the scale of this issue is bigger than thalidomide. Because despite the warnings and communication to healthcare professionals and patients in EU, 1 in 5 women taking valproate in EU are unaware of the risks of taking this medication during pregnancy, and they still take, and the patients still develop cognitive problems, and the babies still develop cognitive problems and congenital abnormalities. So following this study, PRAC recommended new measures to avoid valproate exposure in pregnancy, and there were detailed guidelines on what needs to be done by patients and healthcare professionals to mitigate this. And so, as I said in the earlier slide, there are certain measures that PRAC takes for patient engagement, and through surveys, through those advisory board meetings with the patients, these guidelines have been developed. And so these are the new measures by EMA for this. The visual, they have recommended that there have to be mandatory visual warnings on packaging. A patient reminder card has to be attached to the outer package, and it needs to be discussed by the pharmacist whenever a patient refills their medication. Then it is important that whenever a patient whoever is taking valproate is assessed for the potential of becoming pregnant, and there are regular reviews towards this whenever a patient is receiving the medication. Then counseling of patients needs to be done at a regular level. Then explaining the need for effective contraception throughout treatment, annual reviews of treatment, introduction of new risk acknowledgement form that patients and prescribers will have to go through at each review to confirm that appropriate advice has been given and understood. I've shared this link from EMA, and I think it's a very, very good case study, and it gives us an idea that even though pharmacovigilance has been established for so many years, but still there's a long way to go towards the risk minimization and towards creating awareness in patients. So when I read about this, I wanted to see how it is in our country, and I went to a local pharmacist, and I checked. So valproate is a Schedule H drug. Unfortunately, when I asked, I just asked the pharmacist for the drug, and without a prescription, he was ready to give it to me. Of course, I was not buying. I'm just saying that this is where the awareness needs to be disseminated to the pharmacists, which is also a very unorganized system in our country, so that though there is information on Schedule H drugs, this is important that this information is disseminated there. Also, I saw there were 3 brands that were for which Valproate was available, and only for one of the brands the warning on pregnancy was there. For other 2 brands, there was no such labeling on for Valproate, and this is something I would say we can review, and the CDSCO and PvPI can review there are a lot of medications that have teratogenic potential, and this can be reviewed, and this can be these labeling changes can be made so that patients understand this. Now, all stakeholders together. This is one of the key to implementing patient reporting and encouraging patient reporting. And this is an observation from throughout the world that engagement of patients and patient families cannot be done when all stakeholders work in unison and encourage this. And if we talk about who are the real stakeholders, I'd say, so first of all, the government, the health authority, healthcare professionals and workers, patients and caregivers, patient advocates, patient organizations and groups, and of course the pharmaceutical industry who are manufacturing and marketing the drug. Now, when we talk about how these stakeholders can work in unison towards ensuring that patient engagement is paramount, is functional in our country, I would say first of one of the examples that is already in implementation in our country's National Patient Safety Implementation Framework. And I recently wrote about it, and when I read it, I really realized that it's a fantastic document that talks about not only the way forward, but also what are the lacunae in our system and how we can, through collaboration from all stakeholders, we can really change this in our country and become more patient-centric and ensure patient safety at every level of healthcare. Then there are guidelines recently we have, and this is recently updated and published in 2022, the CIOMS 11, which has a very detailed guideline on patient involvement in development, regulation, and safe use of medicines that talks about how each stakeholder can work towards it. Then we have the Global Patient Safety Action Plan that is that is operational now from 2021 until 2030 with very clearly defined strategic objectives and guidelines. And if I can briefly share the few strategies that have been suggested in the GPSAP, it's like engaging patients, families, and civil society organizations in co-development of policies, plans, strategies, programs, and guidelines to make healthcare safer. Learn from the experience of patients and families exposed to unsafe care to improve understanding of the nature of harm and foster the development of more effective solutions. And it has been seen across the world that patient stories or this information from patients, whether it is through reporting or through collaboration with the patient organizations, they go a long way in really understanding the kind of harm that is caused due to unsafe healthcare. Then build the capacity of patient advocates and champions in patient safety. And this is very, very important because first of all, patients need to be equipped with the medical knowledge and understanding of how they can create a patient-safe environment and how they can take their healthcare decisions along with the healthcare professional and other stakeholders. And establish the principle of and practice of openness and transparency throughout healthcare, including through patient safety incident disclosures to patients and families. And this is something that I would say, and it has been a global observation, that hesitancy to take drugs or hesitancy to take vaccines, and this was seen in the COVID pandemic also, is not due to the adverse drug reactions per se. It is more due to lack of transparency and lack of acknowledgement on the possibility of adverse drug reactions due to these. And if it is established and this awareness is created across the consumers, that because there's lack of understanding that it can be a rare side effect, but if it is an anecdotal evidence as compared to it is an established evidence in SMPCs, the patients will feel more safer and trust because they know this is an established evidence. And if I face such a problem, it can be managed by my healthcare professionals because they have complete idea and understanding of it. Then provide information and education to patients and families for their involvement in self-care and empower them for shared decision making. I'll come to the NGO perspective on, because there is a lot of information on what all other stakeholders can do, and I shared the guidelines for that. So this has been my experience with working as for PhD-Fit, and I have collaborated with some of the patient safety organizations that are working in this field towards creating awareness, and one of them is DSPRUD. And there's Patient Academy for Innovation and Research. And one of the activities that DSPRUD is taking, and PhD-Fit is collaborating with them, is going to the engaging the school teachers for to disseminate to them the knowledge or awareness about patient safety, medication safety. And the sessions that we have done with the teachers have been, it will be an understatement to say they have been, completely fantastic, completely very, very useful, because there is a lot of information that is there that the patients or consumers do not know. And when we take it to the schools, this information gets disseminated to students and then to the families and to the communities. And then Patient Academy of Innovation and Research, they're doing regular webinars on patient safety. They collaborate with an international organization, Association for Patient Organizations. Then there are other patient groups. For example, this is an organization called Patients Engage. They have a website that they share a lot of information on disease areas and how to the help groups or support groups that are there that can help patients. Then there's another organization called medicines.we, where it's also a website that talks about certain that provides authentic information on on disease areas and treatment options. Then one very important and very very, very significant stakeholder is patient groups that for various disease areas, whether it is oncology or diabetes or any chronic diseases or rare diseases, because these patient groups are directly in contact with the patients. They're supporting the patients, and they have direct access to the patient stories. And from there can be a lot of information, a lot of signals that can be created. So if we can collaborate, if the government can collaborate with patient organizations, and this has been an observation across the world, that collaboration with patient organizations brings a lot of information and helps with reporting and assessment. Then there are other organizations, Global Pharmacovigilance Society, ISOP, then ISW Council. There are independent organizations which are doing webinars on disease areas and patient safety. And there is a lot of information that is being shared. So in my next slide, I've spoken about it a little in my previous slide. So how can these patient organizations or independent organizations can really help? And first and foremost, it is for capacity building to create awareness. As I said, they have been conducting sessions on disease areas on through healthcare professionals, and I would like to emphasize that this is not the most of the founders of these organizations are healthcare professionals who have ample information, or the resource persons that they're engaging for these webinars are healthcare professionals who are working in top hospitals. So there is authentic information that is being shared. Then feedback from patient AE reporting. They are a patient's voice, and they can take this patient's voice to the right stakeholders, whether it is the regulatory authority, healthcare professionals, or pharmaceutical companies. It can help affect change in policy at different levels. When we have when we see the signals, and when we see the kind of impact unsafe healthcare may have on patients. And of course, if I talk about what are the constraints towards it, I would say it could be lack of funding and support from authorities. And this is something that, it can be facilitated by PvPI and CDSCO to help these organizations or collaborate with these organizations to make that possible. I would like, in this slide, I would just, these are some sessions that we did with, some of the organizations. This is one of the sessions we did recently with schools. And this is what I talked about. And it was seen, and I would take one simple example, and that's from indiscriminate isotretinoin use. This was this was one of the case study that was shared by one of the teachers. And they said that isotretinoin, if we know isotretinoin is completely contraindicated in pregnancy, and abroad, whenever this medication is prescribed, it is a Schedule H drug. Whenever it is prescribed, it is important that the healthcare professional makes the patient sign the pregnancy prevention program. And was shared by one of the teachers that in India, I mean, in their schools, they're seeing that their adolescents are taking this medication without prescription. They have been, they've been suggested to them by, their saloon or something that they can easily take this prescription, isotretinoin. And even until the time of their marriage, they're taking this medication. And, from this, we can understand how dangerous it is. So this is very, very important that the regulation and this awareness is created on what can be the adverse effect of the drugs. All right. So this example is from the US FDA, and they saw that when they engaged the online communities, patient communities, there was a lot of improvement in the number of reports that they received. And so this example, this is an community outreach program. So spontaneous adverse reporting to the US FDA was encouraged using an easy to use web and mobile app, along with engagement of a Facebook patient group, especially for Assure, a hysteroscopic sterilization device. And they received a total of 1,349 valid reports, and through different channels. And there was a two-way communication, and public posting of narratives led to successful engagement within a motivation, incentive, activation, behavior framework. Reports submitted by patients were considerably more complete than those submitted by physicians and routine spontaneous programs. Okay. Then this is one example, I would say, where we, as PHP Fit, we created some pamphlets. And I think if these kind of pamphlets can be created by the regulatory authority, by healthcare professionals or healthcare organizations, and these are used in hospitals, it can really help in improving consumer reporting. Right. So another point that I wanted to share was that industry. So if we talk about stakeholders, so one is, of course, patient organizations, government. I also talked about pharmaceutical industry. I would say pharmaceutical industry, and I have been from the pharmaceutical industry, and I've been working in the pharmacovigilance domain for a very long time. I would say there is a very, very rich experience in pharmaceutical industry, especially in the CROs and the pharmacovigilance organizations, which are working for global pharmacovigilance companies on the various ways in which the reporting can be improved or risk minimization, because they are working with top pharmaceutical companies, and there are established pharmacovigilance systems in these companies, and there have been a lot of best practices that can be. So I would say, it can really fast track the process if CDSO and PvPI could collaborate with the industry on this and use or utilize the rich experience that industry has, and not just from the experience point of view, but also from the technology point of view, because the technology is really advanced. This is a white paper from IQVIA that talks about the various AI tools that can be utilized to to improve the consumer reporting and assessment. This is my concluding slide, and I would, the pointers on what can be the way forward. And this is from, the observations that I've seen from across the world. So first of all, effective communication regarding signals and risk minimization measures to all stakeholders is the key. And this is, to a large extent, this is done by PvPI. And as I heard from Dr. Ananya Chakraborty, a lot of initiatives have been taken by PvPI. But I think it can be taken forward to the patients and to the consumers so that there is encouragement in medical literacy and understanding of adverse effects so that they can report. Then again, authentic sources of information from the regulatory authority on authorized medicines and disease areas. Awareness about A reporting should be done through different channels so that it reaches all stakeholders, including the consumers. Then I would like to share this, that there's some excellent material, and this is something that has happened during the pandemic, I would say, not just the patient organizations, but from all, so many healthcare organizations, regulatory authorities have created excellent material or content on the various disease areas and patient safety. And this content, though it is there on the web, I would say the views are very, very less. So I would say this can really be used, through at the central level for capacity building. Collaboration and funding at central level with organizations doing genuine work in patient safety should really be encouraged, and this can really go a long way towards creating a patient-safe culture. Then medication safety programs in schools and colleges should, can really help. And of course, this is an initiative that is being done with the medical colleges at an early level, of course. But this has been our experience, and this is an experience from at global level also, that understanding of medication safety or medical literacy, if it is disseminated and awareness is created at an early level, it goes a long way in ensuring patient safety. So I would say these programs that are being conducted on patient safety, they should, if it is possible, they should be made a regular part of curriculum for teachers and students. Then having PV industry as a partner for guidance and technology, and utilize the immense global PV experience with pharmaceutical companies. Again, normalize and incentivize AE reporting by patients and healthcare professionals, because this is there has to be some system which can really encourage patient reporting, and normalizing AE reporting is very, very important so that patients and healthcare professionals can report without any fear. Discourage the blame and shame culture in hospitals to encourage reporting by HCPs. And finally, I would say it is very, very important that patient and HCP collaboration is very strong, because it is often, and this is something that from my interaction with patients, I have been hearing, and there are a lot of talk about it in social media channels also, that until we are able to remove the paternalistic attitude towards patients, it will be very, very difficult to involve and engage patients for patient safety. And that's where I conclude my presentation. Thank you so much. Any questions? I'm sorry I took a little more time than
Thank you so much, ma'am, for your informative session. If someone want to ask any question to ma'am, you're most welcome. I think there is no question. Before going to next session,
thank you very much.
Okay,
Yeah,
thank you so
very
much.
much. Thank you very much for this opportunity to speak at the PvPI stakeholders meet. And they're experts sitting here, and I hope that I have been able to share some relevant points. And again, thank you very much. Yeah.
Madam, it was a wonderful session. We were all patiently listening to your talk, and it was really informative, motivating, and the experience which you have shared with us, I think
I'm in a meeting. I will call
it
you.
will go a long way in really translating how the PvPI can reach to the consumers in their interest, and we will take up we will try to take up the points you have mentioned in your presentation and how it can be how the best practices can be followed to take the pharmacovigilance forward in our country. And I would also like to appreciate you the story narrated by you about the pharmacovigilance program of India. So it was worth appreciating and keeping the image of the country and the PvPI at very high level. So I thank you very much, and we will be in touch with you, and I will request my team to be in touch with madam, and if you have any queries, she will be ready to reply to your questions and vice versa. So thank you very much for your wonderful presentation, madam.
Thank you very much, Dr. Jayaprakash, it's lots of gratitude for what you've said just now, and thank you for this opportunity.
And
Thank you
I
very
will be
much.
requesting my colleague to please take a group photograph of everyone and request all the audience to please open their videos.
Ananya ma'am, please put on your camera.
All are requested to please open the videos.
Okay, thank you so much. Now, I would like to invite Dr. Moin Don to deliver a session on reporting of ADRs and industry perspective. Mr. Moindon, CEO and founder, PVCon Pharmacovigilance Auditing and Consulting Services. He has 44 years of work experience in the pharma industry and is still counting. He is one of the few well-known pharmacovigilance professionals Asia Pacific. He has done B Pharm from KMKCP in 1976 and joined Hawks Pharmaceutical in production, where he had ascended to head by 2000. He has transitioned Johnson and Johnson, where he spiraled to regional PVQA director for Asia Pacific by 2011. He was also heading the PV function at Reliance Clinical Research Service for 2 years. In 2011, on Earth to Work Independently, founded PVCon, which is consulting and auditing servicing firm. He has undergone extensive training in US, Germany, France, and Singapore to master PV. He is certified lead auditor and closely associated with Government of India National Pharmacovigilance Program as advisor and trainer for DCGI and PV staff. He is steering committee member of DIA India and has been chairing DIA India PV flagship conferences for the last 5 years. He is visiting faculty, international speaker, and author of articles in many journals. He is course director of PG Diploma in PV conducted by Academy for Clinical Excellence. He has been recipient of prestigious Pharma Ratan 2016 award for lifetime achievement in pharmacovigilance by DCGI. Welcome you, sir. Over to you.
Thank you very much for the introduction and the nice words. Can you see my slides, please?
No,
Can
sir.
you?
No,
No?
sir.
sir.
We are not.
Okay. Mm. Can you see now?
Sir,
Hello?
please share your full screen, sir.
Yeah. That I will do. Can you see now?
No, sir. No.
Okay. What I would do, I will send this slide deck to you and you can share on my behalf. That's okay?
Okay, sir.
Yeah. Just give me a minute. Okay. I have sent this slide deck to you. Please share it and then I can ask you to monitor and on my behalf and navigate on my behalf.
Sir, on which email ID you have sent?
On your PvPI, where
PV?
I got the invite.
Okay, GOV.
Did you get my slides?
Not now, sir.
I've sent it to your PvPI address.
We are checking, sir.
Okay. NCC PvPI, I have already sent.
Sir, can you please forward to it.nccpvpi@gmail.com? I have already shared on WhatsApp. Can you please?
What is this thing?
Sir, please check your WhatsApp. I have shared email ID.
Okay, sure. I'll do that. Okay, yeah.
Sir, we got it. Okay, thank you.
Okay, you can share it now. Okay, I'm so sorry for this technical hold up. Technologies have their own ups and downs. So one of this is sometimes technology does give us a problem. So thank you very much for inviting me and to give the industry perspective of pharmacovigilance. And as during the introduction it was said, I have been associated with pharmaceutical industry for more than 40 years. And out of that, more than 2 decades, I have been with pharmacovigilance alone. And I have half an hour's time. In fact, I was supposed to start at 12 and finish at 12:30. But I must thank Arshia. Her presentation was extremely insightful, and there was a lot of learning for all of us. And I know, what I'm going to be sharing with all of you, it may not be very new to people like Arshia and some of the people who have been used to working with pharmacovigilance and with especially with pharmacovigilance setup in the industry. Next slide, please. Yeah. So the PV domain, I have divided into three baskets. One is academics, another is regulatory, that is the regulatory agencies worldwide, and third is industry. These are the three most important stakeholders. I'm of course not taking into consideration the consumers and the healthcare professionals because much has been said about this. But I'm going to concentrate on industry, but I would like to have at least some glimpses about pharmacovigilance domain as far as academics are concerned and regulatory scenario is concerned. Next slide, please. So, we have been talking about academics, and I know, and Arshia knows, and everybody knows that we have been talking that pharmacovigilance should be part of the curriculum. And in various forums, we have brought this the notice that not only for medicos and the Ayush alternative medicine courses, the nurses, the pharmacists, at least at the final year level when they are about to finish their course and enter into the field arena, at least one subject or some topics on pharmacovigilance should be included. And it was said that this is going to happen, but I still don't see that happening. And I think CDSCO and DCGI would do their level best that pharmacovigilance is being introduced into the curriculum of all those stakeholders who directly come in contact with patients and drugs, because until and unless, as Arshia was telling, there are a lot of people, the healthcare professionals, including pharmacists, they are not aware of the importance of adverse drug reporting, right? Because they don't really understand where the adverse drug reaction come from, how to report, and what really is an adverse drug reaction, including the 11 scenarios of interest that pharmacovigilance module 6 of EMA gives, where medication error is one of them, right? So this is very important. Of course, we have been holding a lot of seminars, workshops, conferences. I being a steering committee of DIA, and also the South Asia chapter lead for ISOP. We have been now planning to hold a webinar for all students and medicos and healthcare professionals in coming month, and we will definitely go on and advertise to everybody so that some basic fundamentals about pharmacovigilance would be, that awareness would be created among all the healthcare professionals. Next slide. So regulatory, of course, much has been said about pharmacovigilance program of India and CDSCO and their efforts and initiatives taken. And I'm very happy that today, I may be wrong, but sometimes back it was almost 300 ADR monitoring center throughout the Indian territories, and that's a big number. And slowly and very importantly, significantly, the number of ADRs being reported to PvPI has been increasing. And another collaboration which has been made with most of the pharmaceutical companies, that they should simultaneously report to PvPI. That also has helped. So while they send their reports or ADR to DCJ's office, they are also sharing this report through to PvPI, and that adds to the number of ADRs being reported to PvPI, which helps them in signal processing and signaling activities. Next slide, please. So, in regulatory, I have only few things to share because people from CDSCO and people from PvPI are present currently. Uh, we are one of the largest contributor to Vigibase, so this must be appreciated. Secondly, we have also initiated material-vigilance and hemovigilance programs. And we have also have the Center of Excellence for Signal Detection. And we have been getting even messages for some signals which have been generated and confirmed in collaboration with UMC. Then we have also started reporting in regional languages. That is really going to help us out. The only thing what I have been talking to our regulator and whenever we had meeting, that we are still dependent on database of UMCA and we don't have our own database. So we are sharing our entire data, which belongs to India, with Vigibase. And what surprises me is the most that India is the biggest IT hub of the world today. People are coming to India to get IT programs, and unfortunately, we don't have our own database. I'm sure that if we could approach to our IT giants, they will be able to make a customized safety database where we will be the owner of our own data and we can still collaborate with UMCR, WHO, and can be independent of their database. This is one of the recommendation which I'm just forwarding, taking this opportunity which has been given to me. Next slide, please. So I made my own richer scale, positive richer scale. All right. So I'm not talking of academic. I'm now talking of regulators. If I see regulators today in a scale of 0 to 10, we are somewhere around 6. Okay. And we still need to go ahead, and there is a long way to go ahead because the number of ADRs, when you compare this with US FDA or EMA or with MHRA, the what you call the proportion of ADR being reported per million inhabitants of the country, we are down the list. It is even less than 100 number our country is appearing. So I think we need to do a lot over there, and that's what I think Arshia was coming from, how we can create awareness among consumers and among healthcare professionals so that our reporting frequency increases, and this can increase only if we can increase the awareness and we can have various means and channels where consumers and healthcare professionals can report. My next slide, please. So when you come to the industry, I have divided industry into 3 groups. One, we have a lot of small industries, pharmaceutical units. Then we have got big Indian multinational companies. And then we have big giant multinational companies. And if you see the PV scenarios and the PV setup, it is different at different level. Okay, so local operating companies, we already have a guidance document which came up effective Jan 2018. But unfortunately, we have been told in time and again that this is not mandatory. This is just a guidance document. Okay. And according to this guidance document, and if you combine or read concurrently with revised Schedule Y, we understand that each license holder must have a pharmacovigilance officer in charge, which is equivalent to local QPPV. Then they must have some SOPs. Some SOPs have been enlisted. And they must have something similar to what we have in EU, what is known as PSMF, Pharmacovigilance System Master File. And we have another problem in, it is very typical to India. We do not have a nomenclature like marketing authorization holder, what is there in rest of the world. So from a statute point of view, it is the pharmacovigilance obligation on the marketing authorization holder that he solely is responsible for all pharmacovigilance obligation. Now, in that scenario, it becomes very obligatory on the marketing authorization holder to have a robust pharmacovigilance system like we have in all big pharmaceutical companies where I have worked with. Okay. But unfortunately, in India, the manufacturer has got a manufacturing license. The marketing people have a marketing license. There can be a scenario where a pharma company is getting its formulation made by a third party which has got a third party manufacturing license. At the same time, the pharma company is marketing, so they have a marketing license. So it is a gray area and it is not very clear who is the ultimate responsible party or stakeholder for entire pharmacovigilance obligation like it is in case of MAH worldwide. Okay, so this is one of the things which Indian regulators, CDSCO and DCGI will do good if this could be clarified so that we can bring in rigid rules and regulations. If you see Indian multinational companies, so they started with setting up PV function and now they are strengthening existing PV setup. This is basically to cater to the regulated market because now they have entered and some of them are entering into regulated market like EU and UK because now after the Brexit, MHRA is different, EMA is different. They want to go to US. And I'm surprised that even smaller countries like Kazakhstan and all that, they have their own very rigid pharmacovigilance guidelines and they also inspect or they conduct inspection before they register your molecule to be marketed in a small territory like Kazakhstan. So this is the one part of the industry. The second part of the industry, let's go to the next slide, 3.2 bullet. Yes. So big multinational pharma companies, I'm sure, of course, this does not come as a alien subject to Asia, but let us see how big pharmaceutical multinational companies work. And I think a lot of people must be knowing that they have a robust pharmacovigilance system. When when I talk about robust, I'm not talking only to the manpower. I'm talking to the systems. I'm talking to the infrastructure. I'm talking to the various tools. I'm talking to the various software programs. I'm talking about the SMEs. I'm talking about the SOPs, what they have in place. Okay, so I have worked in Sanofi. I have worked in Johnson and Johnson as a Asia Pac quality assurance director. So I know, and I must share with you people that in a company like Sanofi and a company like Johnson and Johnson, there must be more than 100 SOPs on pharmacovigilance alone. 100 plus SOPs for management of pharmacovigilance alone. I know some of the KPOs who are working for case processing for big companies without naming them. I know their bench strength and I know the number of FTEs they are using only for the case processing is more than 500 FTEs for one company alone. So can you imagine the number of areas they are getting and the number of areas they are processing? I have a slide on that. I will come to that on a little more on that. This is basically because they have to comply with EMA, MHRA, FDA, and TGA regulations. Because all these regulations have teeth, and when I say that they have teeth, that if you don't comply, a penal action can be taken against your company for non-compliance. And they find out the non-compliance because they do PV inspections. And when they issue a warning letter, this warning letter is not something, a private affair between a company and US FDA. This warning letter is displayed very significantly on the website of US FDA for everybody to see that what all critical findings related to pharmacovigilance were observed by US FDA. So the linen is being washed publicly, and nobody would like to take that stigma when it comes to big names. We are aware about it, and that's why they have to be very, very careful, and that's why they are pumping a lot of money to be compliant with all the regulations which are there either at EMA level or at UK level or at US FDA level or all the other important regulatory authorities who have teeth for themselves. All right. And secondly, the requirements are very well defined. There is no gray areas. If you ask me, there are no gray areas. You go to the EMA, you go to the GPV module from 1 to 16. Everything is very well documented. People know what has to be reported, what is not to be reported, what format is to be used, whether you used to have local literature or global literature or local case or over foreign case, whether it is serious case, and what type of PSUR need to be reported, what is the frequency, how long it needs to be reported. Now, my understanding with our Indian regulation is that only when a drug is a new drug, that is for the 4 years, you submit the PSUR, and then you are not supposed to submit any PSUR to Indian regulators until and unless you are asked for. So there are a lot of gray areas. Okay, we are not still talking about medication error. We are not talking about lack of effect. We are not talking about the pregnancy cases, which are all one of the scenarios of the 11 special scenarios of the interest, very well described in the module 6. Now, if you see a big giant pharmaceutical company, without naming any company, so if you see their infrastructure, that itself will give you some indication that how they are organized. So they have a PV headquarter where the QPPV might be sitting, okay? Because the most of the PV activities are taken over there, okay? Then you have a safety steering committee and other committees, including labeling committee, which is a very, very important committee. Then you have a PVQA team. Most of the PV, in one of the companies where I was part of the PVQA team, I'm very proud to say that we had 70 FTEs just to do global audits, 70 executives and auditors to do the GXP audit, which was comprising only of GCP and PV audits. So such a huge number of people to do internal audits of that particular company. So every company has got a fantastic PVQA team. In case if they don't have in-house capability, they go out and outsource their audit program to consultants which are there in the market. Okay. other important functions. I mean, each company has lot of what we call as interfacing functions. So it is not only pharmacovigilance alone, which is of course a core function or the center of the focus of the entire activities. But to help them out, we have labeling, we have got signal detection, we have got aggregate report writing. In aggregate report writing, we have everything, right? From PSUR, paperer, PADER, DSUR, annual reports, okay? And then we of course have RMP, what Arshia was in fact she brought up a very important point in RMP, how PPP is being. I was surprised, Arshia, I must tell you, that while working for one of the client, I found out even Jordan FDA had asked my client to have a PPP for their one of the molecules, which is thalidomide, this thing derivative. Can you imagine? A small country like Jordan, their FDA asked this particular company to have a risk management plan, and in which PPP will be a part of it. And we worked together, and this PPP was conducted very well in a small country like JD, Jordan. So we all of us, all big companies have programs which is known as a risk management programs. Then we have global SOPs, we have regional SOPs, and then we have local SOPs. So I was talking to you about that we have close to 100 plus SOPs at the global level, which becomes our center of documented process around everything you talk about pharmacovigilance, right from receipt of a call, a receipt of an ADR, the entire case management, then how the database works, the maintenance of database, how the product dictionary is being maintained, or how signaling takes place, how clinical trials are being done, how investigators' brochures are being versioned, okay, how causality is being done, how labeling is being done, everything related to PV, close to the 100 SOPs. So you can just imagine how well documented, and this does not finish over there. I think the next slide it would be there. We have very robust training system in place. We see to it that our people who are associated with pharmacovigilance, they have regular training on global SOPs, uh, regional SOPs, local SOPs, and all the regulations of the world. Not only in Indian regulations, but we would be knowing European regulations. We will be also very well aware about US FDA 310, 312, and 314. So that's a sort of robust infrastructure and systems that we have. And of course, it goes without saying that each of these companies are using their own safety database. And I don't need to tell you that, you know, the most usually commonly used safety database, of course, they are very costly. Argus or RSG, which are being most, I mean, if you ask me, 80% of the pharmaceutical companies, they are using either RSG or Argus, and both this safety database has, I mean, they have been so well established over last 25 years because they get a lot of inputs from the consumers, and with the help of the consumers they keep developing their safety database. So they are not only customized, they are very user friendly, and there are a lot of suites within each safety database. Like it will have its own signal generation, it can be a hotspot like thing, or it will have its own labeling arrangement and things like that. So I'm just touching the tip of the iceberg. You cannot expect me to cover in half an hour what I have gained over 40 years experience, right? Next slide, please. So then we go to the regional offices. Like big pharma companies, you can imagine, a Sanofi, you can imagine a Johnson and Johnson. They are operating in more than 120 countries. How it will be possible for a big company sitting in New Jersey as a headquarter or Paris as a headquarter to have proper control over a small affiliate across the world, which comes to more than 100 countries, right? So they have regional hubs. So these regional hubs can be for Asia, it can be for Asia Pacific, it can be for Latin, it can be for US, it can be for Europe. Europe again can be divided into two territories depending on how many countries they have. A new concept has come is what is known as the cluster hub. So one hub in Singapore probably would be responsible for smaller affiliate countries of Taiwan, then Indonesia, then Malaysia, and Singapore itself. So one country office in Singapore would be overseeing smaller countries, and this is new concept called cluster company or cluster office, and they will have their own regional SOPs. Very important thing is the regional SOP will not replicate anything from global SOP. So there will be no replication, and they will just add on to the global SOP, which is required at the regional SOP level, which is not there at the global SOP. So regional SOP will be more granular in content with reference to the regional requirement. Similarly, when we come to the local officers will be asked to follow global and regional SOP, but in case if it does not necessarily consist or has any material or content which is required at a local level. Take for example Russia. If in Russia the some part of the PSURs are supposed to be translated in Russian language, the executive summary, then their local SOP for Russia, for PvPI, will clearly says that you follow the global SOP, what is there. In case if the format of PSUR for Russian FDA is little different, then you include that part and also include how the executive summary has to be translated into Russian, how it needs to be quality checked, and how it needs to be submitted. So that's how we have to differentiate between global SOP, regional SOP, and the local SOP. So then secondly, what I would like to say is about the local affiliate offices. So naturally, all the pharma companies, if they have 120 countries where they are operating, it is not always possible that for a small country that they would have an affiliate office. So out of 120, there might be only 100 affiliate offices, but each affiliate office will have its own infrastructure. And in own infrastructure, they make sure that there is a person who is a single-handed or single contact person we call as a local safety officer. We call as a pharmacovigilance responsible person, or we call as an affiliate safety responsible person. And he will not be alone. He will always have a backup. So in case if he is not available, then the second person comes into the action and he has got same roles and same responsibilities as the LSO or ASR. If you go to our main site of a big pharmaceutical company, there would be a share folder where you will find all the contact names, their numbers, their mobile numbers, their email IDs for each and every country where the pharmaceutical company or the MAH has got their products marketed. If it is not that way, my goodness, it is already 1 o'clock. Okay. If it is not that way, then there can be their business partner who would take up their marketing authorization holding obligation, and they will have safety data exchange agreement between the both parties. So they have contacts and agreements as such. Okay. And in case, like I was just talking to you before, that now all the pharma companies have become very wise, and they know that case processing is very labor intense, and that's why they are now outsourcing case processing to various PV service provider. And as you must be knowing that most of the service provider, the India is the most desirable destination of all the pharmaceutical company. You would be surprised, and we should take pride. I have data in my next slide that 80% of the worldwide cases are being processed in India alone. 80%. 30% of PBRs and PSURs are being written by India alone. 10% of risk management plan and other medical documents are being contributed by India. So we have got such rich pharmacovigilance, expertise in-house, and we really need to bring them together and take advantage of this expertise which we have within our own homeland. Can I go to the next slide? I have to be a little fast because I don't want to poach into somebody else's time. So, PV service providers. So, what are the things? What are segments of PV activities is being outsourced? So, as I say, it can be end-to-end service providing, case processing. This could be partial. They would say that, okay, you do data entry, you do quality check. Our drug safety physician will do the medical check and also do the submission. They can also, there can be different models. By mean of different models, they would say, okay, we will give you access to our database. So you can directly work into our access database, or you can use your database and charge us accordingly. So these are the various models in which pharmacovigilance service providers are working. And then, of course, in medical writing, you're writing PSURs, PADers, RMPs, and most of the call centers are being managed either by India or by Philippines. So these are the two most favorable destinations where 24/7 multilingual call center services being provided to most of the pharmaceutical companies and also to the IT companies and big other companies. Next slide, please. Next slide. Yeah. So this was the slide what I was talking to you about. And see the number of FTA. This I had updated, I think last year or so. So I don't have the current data, but this is mind-boggling. We are processing almost 3 million cases, 30 lakh cases per year, okay, in India, whether it is TCS or Cognizant or Bioclinica or Accenture, name anything, combined are now LabCorp, which was Cyformix, and then it became LabCorp. So all these companies together, we are managing and doing case processing close to 3 million, which might have increased now. We have more than 6,000 FTEs working in pharmacovigilance. So that speaks very well for people who are already in pharmacovigilance, or youngsters who would like to take up this as a career path, that there is more and more demand for pharmacovigilance professionals. Then the learning and challenges is that we have created a big pool of PV professionals, but learning in form of enhancing productivity and quality and lack of trained manpower is a real challenge. As you know that when KPOs, they take up fresh graduates, there is a gestation period of anything between 3 months to 4 months that they can be put onto the productive projects. They cannot be productive for that time. That means all the KPOs, they have to train this new fresh graduates at least for 3 to 4 months on pharmacovigilance domain, including case processing, using the database. Then only they can become productive for that. So that is a big challenge, and we have to face this challenge. Next slide, please. There is a very big learning during this COVID phase, and I think you people will be really in agreement with me that it really taught us how to be flexible. Okay, the number of cases increased dramatically during the last 2 years of the COVID. There were a lot of cases reported because of the what we call as the post vaccination. So, how did we take care of this increased peak of cases which are coming to us? This was one thing. Secondly, we really needed a lot of skill set to scale up to really encountered this challenge, right? Have how to train the new people who were taken up from college campuses. And of course, the most important was, and what COVID has taught us, and we are still continuing with this particular model, is work from home. That without going to the office, people were forced to work from home by giving PVN, by giving access to the safety database and through shared folders and whatnot. And there are a lot of companies still, they have immensely gained by work from home model, and they don't want to give up this particular model. So that was one gain for corporates, but I don't think this was a gain for poor people who are working from home and being exploited. I'm very point blankly bringing this point to everybody who's listening to me. Okay, so another important thing which we must learn, CDSCO, all our regulators, our healthcare professionals, we must always remember that all these vaccines were being allowed to be marketed on a humanitarian ground without knowing their long-term safety. We know that these vaccines were developed and brought into the market within 1 year's time or 1.5 years' time. While we know that for a new molecule to hit the market, we need something like 10 to 12 years, including long-term toxicity studies on carcinogenicity, on teratogenicity, and so many other things. So we are still unaware of the long-term safety of these vaccines. So it is the responsibility of all these companies and all the healthcare professionals and also the regulators to conduct post-marketing safety studies, post-marketing efficacy studies, have robust surveillance program to take and record, document, and collect data on the safety information coming out of the vaccines. This is the need of the hour, and this is really a humanitarian requirement. My last slide is, ladies and gentlemen, just go to the next slide. This is my last slide. So on a richer scale, I will see that pharma companies, the smaller pharma companies, may be positioned at around 5 or so, where I include even smaller pharma companies in India. But when we go to the bigger pharma companies, they probably would go to the scale of 7 and 8. And of course, PV service provider have reached right up to 7 to 8. So that is the scenario or status on the positive richer scale for pharma companies and PV service provider. And my concluding take home message for everybody who's listening to this conversation. Next slide, please. Uh, we have come a long way from a non-entity in the PV domain to be seen and acknowledged as a significant international stakeholder and player. This is my judgment. And however, we have a long way to go to be seen and acknowledged as a decision making nation on its own. We still depend on lot on other regulators to take decisions on regulations and which drug to ban and which drug not to ban, because we don't have our own database, right? Or our own ethnic data. So that's the food for thought, and it is really a lunchtime. So I hope everybody will take this food for thought and think about it. All of us, like Arshia said, we have to be together, we have to come together, and this is a teamwork which results into this. And I hope we will work as a team, and we will see to it that India, TCGI, CDSO will be seen as an independent decision making authorities. Thank you so much for patient listening. And if you have some question, I can take for 5 minutes or so.
Thank you so much, sir, for your wonderful presentation,
Yeah.
which is very informative for us. Anyone ask any question? Anyone want to ask any question? If you have any question, you can drop a message in our chat box also.
You can write to me directly. My email ID is very simple, moindon@gmail.com. MOINDON, moindon@gmail.com. My professional ID is moin@pvcon.in. So you can send, I will be most happy to help people, and that's my passion. PV is my passion, training is my passion, and helping and mentoring youngsters is my passion. So even if I'm very busy, I ensure that I would write to you. I'm also on LinkedIn. You can connect me on my LinkedIn profile.
So I think there is no question.
Yep.
Now we are closing our today's meeting. Thank you so much. Thank you so much, all of you, for your time. Have a nice day to all of you.
Okay. Thank you. Bye-bye, everybody.
Bye-bye, sir. Thank you.
Take care. Arshi, I would like to talk to you afterwards. I will call you. Sure.
Thank you so much, sir. Thank you.
Thank you.